Hi and welcome. We're going to look at static posture today. So we've got Ewan as a client. A few things we need to consider before starting this assessment is that this may be done in a sort of confined fitness room or fitness office, so it's crucial that you obviously maintain a level of comfort with the client, don't make them feel awkward. Things like asking if you can locate certain landmarks by palpating or by touching is crucial. You ask them first, and if they say no, the assessment is done purely as an observation. If they say yes, obviously you are permitted. So, Ewan, am I able to touch on certain bony landmarks?
That's fine.
Good stuff. Ideally, if they can wear minimal clothing as is feasible, so if Ewan can take his top off, providing he's comfortable with that. Great stuff. Okay, so with this particular assessment, we can either start from bottom to top or top to bottom. For me, I'll start from the top and work my way down. It's important we don't start from either left or right sides. Okay, we can start from the back if we like, but I always think starting at the front's the best. Now, two questions I'm going to ask you before I start is he wearing any orthotics, which are pre-made shoe inserts normally from a podiatrist? If he says yes, we'll keep the shoes on. If he says no, we'll take the shoes off. So Ewan, are you wearing any orthoses or orthotics? Good, you take your shoes off please, mate. And do you have any injuries that I need to know about?
Nope.
Nope. And if he said anything like I've torn a pec or torn a bicep or injured something, I might note that down because that might give me some insight as to why that postural deviation is present. Now, the first thing that would come to mind if someone was to be performing a postural assessment is to stand up nice and straight. So to avoid that, I need to get Ewan to close his eyes and march on the spot for me, please, Ewan. And relax. Good stuff. We're going to start at both ear height to see that they're both level. Good. We're going to assess both shoulders to see if one shoulder is higher than the other. Good. I'm starting to think that left side's slightly higher than the right. Combine that with a bit more of an increase in hypertrophy in that left upper trap could indicate a shoulder height differential. We're going to assess arm gap to ensure the same distance from his torso and his arms are the same. We're going to work our way down and palpate both ISs on both sides to see if there's a lateral pelvic tilt or indeed a hip shift to one side. Now a hip shift, I'll just get Ewan to perform one, will be leaning to one side and hyperextending the knee that he's leaning to. He isn't, so we'll get him to march on the spot again just to reset that. Good stuff. He looks pretty level on that instance, so from what I can see from this observation, it's only just really a shoulder height difference. And as he might be looking slightly to his right, so you're seeing a little bit more of the left side of the face than the right, and that could indicate a tightness of the right SCM or sternocleidomastoid. Okay, I'm happy with that, Ewan. Could you turn to your right 90 degrees, please, face that way. March on the spot there again, please. So when performing this assessment laterally, really what we're looking at is an imaginary plumb line which should, in theory, bisect the ear, the back of the humerus, the hip, the knee and the ankle. That would be ideal. No one on this planet has ideal or perfect posture because gravity has always won, so to speak, so there will be some deviations. So anything that's positioned in front of this imaginary line, called a plumb line, is considered a deviation. So starting off, we're going to see where Ewan's ear is in relation to that imaginary line. If you don't want to just use your eyes, you can hang a piece of string with a fishing weight off it from the ceiling to give the line of gravity. So his ear's a little bit forward, but nothing I'm too concerned about. This line bisects the back of his humerus, goes through the hip and goes through the ankle and the knee pretty well. From there I'm going to assess his thoracic curvature to see if there's an adequate thoracic curvature there. I'm quite happy with that, it's pretty flat. Then crucially I'm going to look at the lumbar curve to see if it's excessive or deficient. Now for that, what I need to do is to determine the position of the pelvis, whether it's tilted anteriorly or posteriorly. And what that means is if his pelvis is moving towards the plumb line or towards the front, that would be an anterior tilt. If it would be moving backwards, that would be a posterior tilt. So march on the spot once more for me, Ewan, just so we can reset that posture. And relax. Just to flex your left elbow there, mate. Okay, so for this I need to locate his ASAS, which is just about there, which is at the end of the iliac crest, and the opposite number, which is the PSAS, which is sometimes manifests itself as these two dimples on the back called Venus's dimples. Now I try and connect my fingers imaginarily with a line to see what that height difference is. We want the difference in men to be about 1/2 inch and 3/4 inch for females. The reason for that is that the pelvis has a natural, or should have a natural, anterior tilt in it. That natural tilt gives rise to the natural lumbar curve which we need. Okay, so we're going to use both the pelvic tilt assessment, and we're going to have a feel to see if that arch is either excessive or reduced. I'm pretty happy with Ewan's lumbar curve and his pelvic tilt, so there's no issues there. Okay, Ewan, we'll get you to turn 90 degrees to your right, please. March on the spot for me. Good stuff. So again, we're going to check the ear height, see if they're level. I'm going to check the shoulders, and I'm still confirming that left shoulder is a little bit higher than the right, so there could be an upper trap tightness just down there. I'm going to check for scoliosis, which is a lateral deviation of the spine, just by basing my hand on sort of T1, first thoracic vertebrae, and just running my fingers down and just ensuring there's a vertebrae beneath the other. That looks pretty straight. Okay, well, I don't have patella to contend with in this position, but I do have scapula to contend with, and from there, if I highlight each inferior angle, which is about there on that side, and on that side, we can see that that left scap is higher than the right, so that confirms my anterior assessment that there might be a left shoulder elevation. The scaps, as you can see, are slightly winged in that their medial border and inferior angles lifted from the thoracic cage. I test this by just seeing if I can squeeze a few fingers underneath there and kind of move him, which I can. So certainly there's some level of winging of the scapula on both those left and right. That could indicate a tightness in pectoralis minor and a deficient rhomboids lower traps and serratus anterior, so we would address that through exercise prescription and corrective exercise therapy. Ears, again, just to refresh. Shoulders, check the AC height, highlight the differences of scap height or winging, ensure the spine is straight and not laterally deviated. We might also just check the two pelvic landmarks. They can sometimes manifest themselves on the skin as Venus's dimples, those two dimples that the PSIS can create. That all looks pretty good. I'm happy with the arm distance on both sides, nothing too drastic just there. What I might also check is just whether the feet are sort of collapsed or pronated, so to speak. And by that, I'm just going to place my fingers underneath his arch, and I can get a pretty good sort of fingernail thickness through there, and the other one just on there. And I'm happy with that. Okay, Ewan, if you turn 90 degrees to your right. Again, I'm looking at really the spinal curves there and referring to the plumb line. Now I can see that that shoulder is slightly further forward than the left one, that right shoulder. So there could be a tightness of pecs, anterior delts, and possibly subscapularis. So we'll make a note of that. Get Ewan to march on the spot there again, please. Good stuff. Okay, so he's pretty straight. I'm, again, comfortable with his thoracic curve. He does have sort of a tightness in the shoulder girdle, so pec minor, pectoralis major could be a slight overactive, so we want to address that with some strengthening of the rhomboids and the serratus anterior, but I'm reasonably happy with that. His lumbar curve, again, on this side seems pretty sufficient. I'll just assess his pelvic tilt. There's his ASIS, find his PSIS, ensure there's 1/2 inch height difference approximately, and I'm pretty happy with that. Okay, it's pretty straight. Okay, face the front once more, and I'll just have a quick overview of your symmetry. Good stuff, and that left shoulder is certainly higher. The other thing I do want to consider is ensure that the kneecaps, particularly the apex of the patella, which is the end point, if you like, is in line with the second metatarsal, so the toe lateral to the big toe, which I'm pretty happy with. So overall from you, and just to sort of summarise that, we've certainly got a left shoulder elevation, which could be indicative of tight upper trapezius, levator scapula, and a deficient middle lower traps and rhomboids, so we can look at addressing that with some corrective work. And tilt-wise, he's pretty good. Maybe a slight protraction on the left shoulder, which would require a bit of stretching of his of his pecs, subscap and anterior delt. And that's the postural assessment done statically, as a static observation. From there, we would incorporate a movement analysis to really expose any of these deficiencies through movement.